Finally, I talk about late arrival. All right, here we go. So now we're on and we're recording. I'm going to finish up what goes on here. And I will bring in those, gosh, fashionably late. Why not make an entrance? Where, this could be like, we take pictures like you're coming in on the runway. I like that. Like everybody has like, they play the music when you come in. They're sort of like their theme song. We should do that. Don't know how my daughter did that stuff. She did that modeling and stuff. Oh my god, crazy, crazy. So here, this is kind of this is what I was just saying. For you late arrivals, I don't want you to feel shortchanged. That I wanted to just review this. This is pretty much the end of what's on the exam. It's basically, I think the exam is a little bit on joints, and then basically the central nervous system and the peripheral nervous system. I was saying to you before, is I'm not sure that the eye is on it. I'll double check because I finished it. I just don't recall exactly if I put any questions. That's something we're going to go over here anyway, and I think it's more pertinent to lab. So I wanted to get some of the eye anatomy out of the way here, what we're going to look at, and we're going to dissect the eye in lab. I sent you guys a link, and we'll project that because it's a sheep eye, but it's much, the cow eye is better because it's bigger. And I think it's a really great dissection to do. So let me start from here. We were looking at. Remember, we had. I just felt I went through it a little faster than I should. So the two plexes, the lumbar and sacral plexes, and the big deal here, again, the division of the lower extremity. When we're talking about the thigh area, basically it's divided into three compartments. The anterior compartment, which is basically the quadriceps muscles, the big muscles in front of your leg that basically let you kick out your knee and straighten it. The adductors, those big, thick, what we call groin muscles in sport, they're so powerful. And then everything else is in posterior. The only oddball is the adductor magnus. The adductor magnus, which is the largest of all those quote-unquote groin muscles, has enough of a component in the posterior portion to be serviced by the branches of the sciatic nerve. So the big nerves, to know a little bit about what they do, the femoral nerve, and that's basically the quadriceps group muscle, and then the obturator nerve, named because it goes from the obturator foramen, and obviously there's sensory elements, and you can look through some of this that's there, but these are the big guys. Part of the adductor magnus, all the other adductors muscles. The gracilis is the most, and I will send you about, I'm not going to ask you that, but the gracilis is the most medial of all the muscles. It's like a strap muscle, and it was named because it was so graceful. That's why he got the name gracilis. It was just very, whoever they're dissecting it, they found it to be particularly, there's just something about it that struck them as a sort of like a graceful elegance, was the way it was explained to us in anatomy class. Femoral, and the big thing, I mean, it has a lot of sensory stuff, but the big players are the quadriceps, and what you'll see is the sartorius. So I do owe you that, and I'll have a chance to get on that, because I don't think it's the type of material. I think it's more contextual than me having you name that muscle for anatomy, because I just don't like teaching. Sorry. I'll get over it. Sacral plexus, a little bit lower, where this is lower lumbar, L4 and L5, all the way effectively through the rest of the significant sacral nerves through S4. The rear, so buttocks, we're looking at the gluteal muscles. Posterior aspect of the thigh, pretty much all of the leg. Some pelvic structures. The perineum is the area. Perineum is sort of from pubic symphysis to the ischial tuberosities to the coccyx. That triangular area we would call in the female the vulva, and the male we just say perineal, like this. So, and really it's all about sciatic nerve for our purposes. Hamstrings, the giant muscles on the back of your leg, most of the adductor magnus, most of the muscles in the foot, leg and the foot, Again, the two nerves, this is clearly a test question. What are the components of the sciatic nerve? The tibial and the common fibular. And what happens when something is common, it means it's going to split up. And indeed, you might remember me commenting to you, it's around the neck of the fibula. That's why when we're putting a cast on or some type of immobilization or anything that would compress that area, we make sure we go below that area, because that will create effectively what we call a drop foot, putting unusual pressure on it. You always look for where, it's like your funny bone. You look for where nerves don't have a lot of protection from fat, muscle, soft tissue. You have to be very, very careful of that, because that's where problems occur. So the tibial nerve, again, pretty much all of the foot from the tibial nerve, a lot of structures in the leg. And again, we're not going to go over all those muscles, and I wouldn't be asking you questions in general. So the fibular nerve, okay, used to be called peroneal, and that was a little confusing with perineal. So now they call it fibular nerve. That was changed. When I learned about it, they were peroneal nerves that were part of it. And then, and again, some of the muscles, and I don't want to go into all those for your purposes. And you can see here we're getting into the areas. So this has some genitourinary implications. We sometimes see people with damage here. It can lead to some type of sexual dysfunctions and things like that. Just so you can see that large area. You might remember that greater sciatic notch. That's there, how it comes through all of those areas. And here's that large sciatic. And you see multiple branches feed it. Comes out through the sciatic notch, a small portion through the lesser sciatic notch. And you can see here in that, this is the popliteal fossa, that area. And right around the neck of the fibula, common peroneal separates, the tibial continues straight down, servicing some of the muscles posteriorly behind, and it should be a little bit more in the medial malleolus here, and then into the foot. Whereas this winds around the neck of the fibula, and you get the deep and superficial nerves, and they service others. Deep fibular nerve would service the muscles that allow you to pull your toes through your nose, and the superficial one is more lateral aspect and calf areas along the lateral aspect, just for the sake of completeness. And you can read through that as easily as I can read through it with you. And so all these things, this is the idea. When you have a disc that bulges, like mine did, it depends on what plexus it is, okay? Lumbar plexus are compressed, gait problems, pain or numbness is what I had, anterior thigh and over the knee. Femoral nerve, prime movers that flex the hip like this and extend the knee. I fortunately didn't have the motor, it was just sensory. Obturator, pain in the medial thigh. Sciatica, very common problem. It's just, so many people will, it's a generic term, pain going down the back of your leg. And it just depends. I mean, so sometimes it can be sensory, sometimes it can be motor. It's all about what part of the nerve is being impinged, what the disc is pressing on, if indeed that's the source of the problem. Is it arthritic in nature? There's, it's part of the workup to find out what these things are. I read you should keep abreast of things, but particularly local events. There was because you see that Heritage Valley is being acquired by AGH. You see the Allegheny General Group, West Penn, Allegheny, are unfortunately at two hospitals, at Heritage Valley and I think at Upper St. Clair or Jefferson. I don't know which groups that they're in. They were finding statistically there was an excessive number of back surgeries. You got to understand that this is something we professionally, we who are providers, and became the world of managed care, when basically insurance companies and the people who did accounting and people who did actuarial tables ran the numbers, and they saw they were paying for a lot of procedures that were over what typically they would expect for norms of the population. This is something hospitals have to watch out for. I mean, when I was doing procedures, we did bunionectomies, And when I first started, you operated, you send the bill, and they paid you. Now most of the time you have to get what's called pre-approval for things like back surgeries, carpal tunnels, because so many of them were being done. It's called overutilization. And you have to, I mean, those are the kinds of things, if you go into a professional practice, if you become a provider, whatever your services are, you got to be very, very watchful, because money's a big issue, and people don't like to see this stuff. So the injury could cause by anything. Again, people injecting in the wrong site. Nerve, leg is nearly useless, cannot be flexed because the hamstrings are paralyzed, for instance. Foot and ankle, this is the foot drop. Again, that's what I was telling you about. You can induce that by putting pressure in the wrong place, and casts are really the biggest culprit. So nerve injury is usually slow, okay, and it just depends where they are in different. And this is stuff that I had a lot of experience with. So I mean, I just for the sake of completeness, and the intercostal nerves we'll talk about. They basically play a role in respiration. That was the next part I was going to send you. Basically, the external intercostals. These are all from the thoracic nerves. When you're the only time you really fire muscles to breathe are external intercostals. That helps you expand your chest, and the diaphragm, which flattens. So effectively, and we'll get to the physiology of it. It's all based on the ideal gas law. Pressure and volume have a constant relationship. So by expanding the volume, we decrease the pressure, it creates a negative pressure, and it brings the air in. So a lot of that, and so when you inhale, you're actively doing. When you exhale, it's just relaxing the muscles, and it goes out automatically, goes back to its resting state. So unless you're doing a big inhale or you're blowing out the candles, and we're actually going to do that experiment with technology, and that's how we examine things like vital capacity. So that's where this ties into in the physiology component. So some of the technology I had set up last Monday, which I'm going to wait for next Monday and do it, because it has to do with eye and ear, and it'll give me something hands-on activity for us to do. So today's the eye dissection, then we'll have a week off, and then the following, whatever that first Monday in November, which I guess would be 3rd, right? The 3rd. We'll probably do the heart dissection. That big ass cow's heart. And dermatomes. So when you do a physical exam, and you take like a sterile pin, like I would do, like a sterile needle, delicately go to certain areas. What are we looking for? So this is where dermatomes come into play. And the dermatomes, there's an overlap, so it's not just one. So here, this is a dermatomal chart. This is different. These are very scientific. If you like to look at fun stuff, there's things called meridians. That's the basis of, if you did not know, acupuncture. And I'm not making light of these things. A lot of people are helped by acupuncture. Reflexology, places on the foot. I mean, there's a certain amount of science behind these. These are medically. So if you wonder what a knee jerk, L3, L4, and L5. Typically, with knee jerk, we usually categorize it as it creates a problem, L2, L3, L4. And then you can test to see if they have sensation in those areas. So if you're testing the Achilles reflex, it's typically L5, S1, and S2. Yeah, the person's is on a table, sort of up on their knees with their heels hanging off, and you test to see the Achilles reflex. It's all the types of things that are done. And this is Hilden's law. Any nerve serving a muscle that produces movement at a joint innervates that joint and the skin over it. For future reference, I won't ask you about it. So we're done with that chapter. That particular PowerPoint. And I did this out of sequence because I wanted to do the cranial nerves, because there's a whole bunch of that on the exam. And again, I should get that review recording out to you. I'm sure I will not have time today, because I usually beat when I get home, and there's 2 football games. Did you catch the Denver and Giants game? I know it wasn't broadcast here. My son and he had Giants for his loser in the loser pool. My survivor pool was Denver. And in 19-0, I'm going, we're done. Using a different word for done. Beginning with an F. I mean, 33 points in the quarter. Only the New York Football Giants. Yes, ma'am.
You upload the study guide?
Didn't I send you the study guide? Oh, that means I certainly did it. I'll resend it for you as soon as I get to the office.
Like upload it in the Blackboard instead of
Absolutely. I'll be glad to.
and also you know how you had like issues and then like a document for it.
Yeah.
Scan in the document. Stuff for like this exam too. Like,
The only one I have is joints. I don't have one for nerves. Sorry. They resume again when we get to endocrine, heart, blood vessels, okay, digestive and urinary. Digestive. I'll have them coming back for you soon.
Okay. Can I give us all of the stuff you have for the testing?
Certainly. But I don't have a lot on the nerves. You get over it.
I won't.
Yeah, don't be cute. Mm-hmm.
I need it.
You'll go. Life is good. Yes, sir.
Just joints and nerves or muscles?
I don't think there's muscles on it. I will find out. I mean, I will answer those questions in lab. Because I send it to the printers. I don't remember. I was celebrating. I finally had something over Dr. Buxton. Man United, for the first time in 9 years, nearly 10 years, won in Liverpool. In the biggest football with a U match in England. Arch rivals. He and I are opposed, diametrically opposed. He's had it on me for the last like 10 years. I don't like him anyway. All right, so we're starting from the beginning. This is A. I do not want to do the physiology. We are going to we use these PowerPoints again, physiologically speaking. Jen, I'll tell you what I'll do. I will look on the authors. They have outlines. If I find them, I don't know if they come with the old software package, which I have access to. Okay, and if it does, anything I can help you with, I'm happy to help you with.
You can help us by like giving us the test beforehand.
Yeah, that would be that. I know that would be unusually helpful. That's as likely to happen as I'm trying to think of it. Me being able to run a marathon.
Oh, I think we can do it.
Yeah, right. My soon-to-be 43-year-old son is going to run like his 6th marathon. I have no idea why. Oh, good Lord, love it, Duck. He's running the Marine Corps marathon at the end of soon, maybe next weekend.
Time to train.
I give up. Okay, peripheral nervous system. Our focus is going to be special senses for now. So we're going to look at eye and ear is really where our focus points are. Generically, they are part of the peripheral nervous system. And effectively, they're all about the sensory division. We will get into these other divisions as time goes on. Most of this, okay, is we're going to be looking at these mostly in physiology. So, and this is the type of stuff, the definitions that are there, and I'm going to come back to it. For instance, remember, it's like you have things going on inside, they call it internal receptors. Things like feeling outside, if something landed, one of the bugs is doing the dive bomb at me, that's an exteroreceptor. And I told you a lot about proprioceptors, sensors that we're getting to that. It's not part of this exam. I'm just trying to give you the logic why I'm going to go back to it. And all the different levels that it's in and how the signals and transducing it. I'm not going to go crazy with that. And I don't do this not because I don't want to. I really, it's not that critical. If you're going into a field or you're going to do research in neurology or doing testing in that area, that's where this becomes relevant. This is very much, to my thinking, I mean, if you're going to neurology, you would want to be familiar with this. But the reality is this is mostly graduate stuff where they would really explore this with any degree of depth. So I don't feel the need to do any of that. We're looking at these different circuits. What is important for this is, you remember we talked about sensory circuits. Most of them have first, second, and third order neurons. They have 3 levels of neurons. One at the sensory level, wherever you're feeling it. The second one typically ends up in the thalamus, and the third one, the thalamus sorts, edits, and shoots it with the third order one to the appropriate part of the brain. Sometimes there's a 2-nerve circuit that ends in the cerebellum. The one track you're going to need to be familiar with is that lateral spinothalamic, hot, cold, sharp, dull, pain. That's a 3-nerve circuit. So I'm telling you what's on the test. You're writing this down. I know you're probably looking at something else on your screen. I'm going to get one of those, like, the blink system cameras and stick it back there. And I'll be able to see what you guys are doing on your... You don't smile. You're looking at designer clothing. You're looking at, FanDuels or DraftKings. You want to see what to gamble on. Just saying. See, if we had, I'm only sorry I'm not your age. We could have had all this in class. I would have such a good time. You have the one little thing in your ear, so you really don't know what you're listening to. We had transistor radios. Do you know what those are or were? Does that have any connotation? You had those little 9-volt batteries, typically in the early days, and you had one little thing you plugged in your ear. You could be in class, hide this thing, and you had that in your ear. Listen to the game. Not doing that. Not doing that. I'll come back to it. Pain we'll talk about. Pain is hard. Okay? Pain is it's something going wrong. Pain is a warning sign. It's that idiot light in your car. You ignore it at your own peril. Please. I'm telling you all the time. And we'll talk about some of the things that mediate it when we get there. Remember I was telling you about that substance P with capsaicin? That's one of these neurotransmitters we're not terribly clear of. It doesn't work for everybody. And when we get to the this is more physiology, we'll talk about endorphins, which means endogenous morphine-like substances. We make those. If you did not know it, we make substances that are related, that are cannabinoids. So they're related to THC, tetrahydrocannabinol, which is a very complex molecule. That's the active ingredient in marijuana. I mean, it's remarkable. And we'll talk a little bit about pain. So I'm just trying to give you, and we'll talk a little bit about visceral and referred pain. Referred pain is very interesting. I'll get back and we'll talk about this chart. It's there, and that's why, and I'll reflect back on it with regard to the fibers, just to give you the general overview, what it means. So you always hear somebody, well, one of the things you look for, someone comes to an emergency room with, they have pain going down the medial aspect of their left arm. It's somebody like me. If you get somebody who's middle-aged or older and, all of a sudden they're developing that kind of a situation, trust me, the first thing, if you do this routinely, the first thing you rule out is the thing that A, is the most likely to kill somebody, and B, the thing is pretty obvious for who they are. So if they're middle-aged or older, you start thinking heart right away. And so that's why, and effectively, the pain fibers from the heart, which are limited, follow the same circuits as the one come from this portion of your left arm and this area of your chest, also in your neck area as well. So that's a lot of things. So if you get somebody like me who has overweight, high blood pressure, I don't have a history of heart problems. My dad didn't survive open heart surgery. Okay, to give you some ideas, and I come in with indigestion, I come in with chest pain, I come in with arm pain, I come in with difficulty swallowing, or I'm just in there and I don't feel good. Trust me, they're going to start to work up the possibility of an impending heart attack. They just are. You'd be remiss if you did not do that. So wait, always assume the worst. So then this other one, this is really relevant. A lot of procedures today are done arthroscopically, and a lot of procedures are done endoscopically. So in these, we talked about arthroscope and endoscope. How would you do a tubal ligation? Endoscope. How would you do a gallbladder? Endoscope. Appendix, endoscope. A lot of these are done endoscopically, meaning fiber optic tube is inserted into the abdomen, and under what we call direct visualization, side probes, you're able to do the procedure. In order to do that, you have to blow up, inflate the abdominal pelvic cavity with gas. So typically use a gas that's not whatever gas they're using. I don't know. I think it's mostly nitrogen or a nitrogen gas mix. Effectively, what it does is it puts pressure on the diaphragm. So every patient, if you have them or you're in this, or you are having it or your significant other is having it, they're going to tell them, don't be surprised if you wake up with pain in your shoulder or you're up the clavicle or shoulder area. That's the first place. They'll say, we've operated, I had a tubal done. Why is my shoulder hurting? Because the gas blew up the diaphragm. That's an example of referred pain. Why men, more so than women, although it happens in both, get testicular pain. Your ureters are in the lower inguinal region. In male and men, inevitably it's testicular and penile where they have that. We'd have somebody come in and go, oh shoot, they have it's just a kidney stone. And in women, it affects the same area. It's getting more common in women than it used to be. Younger women. And then phantom limb pain we'll talk about. So I didn't want to skip this. I wanted to give you some context. And then there's the category. We have different kinds of receptors. We'll go into that. Typically pressure, hearing, thermal, heat, photo, light. That's what we'll talk a little bit about. And chemo almost everywhere else. Chemoreceptors predominate. So down the road, not for me now. I don't think it's on this exam because I think it's pure physiology. These are the 4 basic types, and the one for pain have their own name, nociceptors. Okay, sensitive to pain-causing stimuli, thermal, pressure, chemical in orientation. They stimulate a lot of different things. Nociceptors. So down the road, you have to know that, and this is the external and internal stuff, and simple and general, and complex, and nobody cares. And I'm not doing all these things. There's anatomy in this. Okay. I just don't. Most of the free nerve endings, okay, are the ones for hot, cold, sharp, dull, pain. Remember, if you're thinking about light touch, those Merkel cells from the epithelium, when we look at the skin, sit on top of those free nerve endings. So that's light touch. Encapsulated are deeper. And in classic anatomy, we go into a lot of these. So non-encapsulated, temperature, pain, light touch. Dermal, depending if there's extremes, superficial dermis, you can go into parameters. And so all of those things, you yourself know when something's excessively hot. I mean, things like that we get used to pretty easily. Okay. I mean, when you're getting heat receptors, it's like we have a small hot tub stuck in our deck, but it only goes to 104. So when you get in there, it's pretty hot, but the reality is it's not that hot. That's 40 degrees Celsius. You get used to it right away. Mojitos, midnight, hot tub. See, I got you. Gotta have one. We don't use it as much as we should. Wife likes to go, oh, this is right now when it's getting cold at night. Oh, let's go out there. We did that in the snow. Oh, it's terrible. I mean, when you get out, you are effing freezing. Moving on. So there, I don't go into vanilla, and here's, ion channels by heat and etc. Capsaicin and red peppers, blah 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 blah. These and again, whether it's those Merkel cells, whether it's feeling around a hair follicle, I mean, those are things that really a variation of light touch that are there. Encapsulated are very specific. These are the two that you hear the most about. These are names I would remember. Going forward, I would not have them on this exam. I'm pretty sure I do not. I will surely guarantee you one way or the other. I wouldn't spring that on you. These are Meissner's corpuscles. They're very distinctive, hairless areas, very sensitive fingertips. And these are deep pressure, particularly vibration, okay? Deep dermis. And what's interesting about that, that's an interesting sensation I'm familiar with. That is the first sensation. Diabetics are prone to a disease called peripheral neuropathy. About 1/3 to 1/2 of all diabetics, even if they're well controlled, can get this. And they can totally lose all of their sensation. The first sensation to go is vibration. And effectively, I'll show you a little bit in the lab. Now that I'm thinking about it, that's why I have tuning forks in the lab. And that's when you do a neurological exam, you're always dinging the tuning fork. Because it has to do not only with hearing, but with being able to do different types of sensations that are there. And there's other ones like that. Spindles, these are basically tendon stretch organs. These are, by definition, they're unique receptors. That's why when you do stretching exercises, I don't know what it is for you guys in sport. So are you doing, what kind of stretching are you doing before or after? Pardon me?
More like openly, like dips openly.
You mean before?
Yeah, and then after it's more.
What type?
After it's more like vocal stretching.
Yeah.
Sit down, stretch.
Yeah. So it's more, and that's pretty much consistently. I mean, if you watch Premier League soccer players when they're warming up, very active. And what you're trying to avoid afterwards, the best time to really sort of elongating and that more static, elongated stretching, probably after than before. Yeah, and it's changed over time. We used to do all those ballistic stretching, but something they did constantly before and after. It changed a lot. So it has a lot to do with these things. What you're trying to avoid reflexly. I mean, it's really difficult. So we know it's the whole science of exercise physiology and athletic training has evolved light years, really. And that's why it's remarkable, the distinction in athletes. I was telling one of these other classes, I mean, go back and you can see videos of very famous, the NFL before people even watched football. It was never the number one sport when I was a kid growing up. Not even the first Super Bowl, and I effectively have seen them all, maybe except for two. The Giants in 57, 58, one year they beat the Colts, and with Johnny Unitas, the next year they didn't. And what happened that was interesting, they had, if you watch the size of the players, the Giants had one of the all-time great defensive ends named Andy Robustelli, who was maybe generously 6'1.5", 2 1/4. Gives you an idea of the size of the players. If you're thinking of how big a defensive end, think about Cam Hayward. Think of the size of that man. He's huge. If you ever see him in person, he's just huge. We were in the Apple store over in Rosemark Pool together. I'm walking by this mountain of a man. I'm like, shit, it's Cam Hayward. And his little daughter was like he brought the car seat in with him. Crazy. But the size has differed so much and the training has differed so much. It's just remarkable. And this is just showing you some pictures. So this is what they're like, these muscle spindles, stretch receptors, things like that. But these are the ones that Meissner's corpuscle and the Pacinian corpuscle are the only two I remember if we're going forward. And so this is really where the focus point, and it's a good introduction of what we're going to look at before we dissect the eye and lab. Okay, 70% of your sensory receptors in the eye. We're so visually oriented. Half of the cerebral cortex processing. We're dedicated to that. We are visual in nature. And indeed, it's a relatively small sphere, and what you and I are seeing visibly is only about 1/6. 5/6 of it is inside, protected by a relatively generous fat pad. And I don't know, when we look at the ones, I think the fat has been mostly removed, maybe not all of it, and then the accessory structures. So anatomically, it's easy. And you probably know all these terms anyway. We know about eyelids and eyelashes, but the opening is referred to as the pupil. The iris is the pigmented portion. You will see that that is the extension of what's called the vascular layer. And it varies obviously from person to person genetically, although we may all have similar colors. There's a lot of variation that's there. It is covered by a clear, relatively unique connective tissue called the cornea. That is clear. That covers this portion of the eye, the pupil and the iris. The extension of those fibers, which are mostly collagen fibers, how they are arranged, they are transparent. They become the white of the eye, which is the sclera. Sclera for hard. You're going to see there's 3 layers. The hard outer layer consists of the sclera, the white of the eye, and the cornea. They've made similar fibers. It's the orientation of the fibers makes one opaque and one clear. Those little blood vessels that you see are part of a membrane that covers not the cornea area, but the white of the eye, very famously called the conjunctiva or conjunctiva. Okay? So the cornea, the conjunctiva stops here. It goes all around those areas that are exposed, enveloping it with little pockets surrounded. So when you have pink eye, that's the blood vessels. When that conjunctiva becomes inflamed, that's where the blood vessels are. The blood vessels engorge with blood against a white background, they become more visible. So, I mean, if you're rubbing your eyes because you have allergies, they might appear what we would call bloodshot. Obviously, certain substances dilate those, like alcohol, and that's why people with chronic alcoholism dilate blood vessels. So they'll have bloodshot eyes. The blood vessels on their nose will expand and become visible. So you can tell if somebody has a certain degree of chronic alcoholism. That's all part and parcel to this. So yeah, and the other thing, I don't really care about lateral commissures or medial commissures, or the caruncle is that little bump, and that's really overlying. You might remember the lacrimal bone has a little opening for it. That's the lacrimal duct or tear duct. That's a 2-way passageway that basically can carry infection from the nasal cavity up to your eye. So one way you can get conjunctivitis is from a nasal infection. And the way most people get conjunctivitis, particularly little kids, eye rubbers. Little kids' hands are dirty, they get tired, they rub their eyes. Trouble. I'm a chronic eye rubber. My wife is threatening to tie my hands to stop from eye rubbing. I mean, eye rubber's anonymous. We meet annually. It's a 2-step problem. 2-step factor. Stop rubbing your eyes or else. And so all these things I don't really care about. The conjunctiva I care about. We did the extrinsic eye muscles. Please, that's really important. That's something that I think is on this exam. I'll double check to make sure, because it has to do with all those neat holes, like the superior orbital fissure. I'm going to review them again here. So the lacrimal apparatus I'll just show you. and that's effectively where the tears are produced. It's kind of neat. The lacrimal gland is here, the duct is here, and as we blink our eyes, it's almost like the spritzer on your car. You know, when you're trying to clear the dirt off your windshield, it's like it comes like the one in the back. Oftentimes, in the back of my VW, it kind of comes from the top and spritzes, and then the wipers. It's kind of what your eye does. The same thing. It's just tougher to add fluid. Nobody thought that was funny. Shade. Yeah. Anatomically, I'm not going to ask you because I think the terminology is dumb. They're also called palpebrae, your eyelids. They have a slit. Did you know that? They have medial and lateral commissures, the edges. They have the caruncle, and this is called a tarsal plate, wherever that is. And they blink very, very frequently if you did not know that. And really, that's what you're doing. You're constantly lubricating it, moistening it, and you know, when you get some near eye, how rapidly you blink it. Okay. Again, reflexes, the eyelashes have that. If something, you know, basically contacts them, we have a number of glandular structures that are there. Basically, they're really modified sweat glands. Would be the best to describe. It's not ones I don't ask questions about that, but that's a pretty good illustration to show you the continuous nature of the cornea clear and the sclera. Again, they're part of this hard outer layer, and because we go back to the original Latin, they're called tunics. So you have the tunica fibrosa, fibrous tunic, the vascular tunic, and then you have the nervosa, the nervous tunic. Again, get used to seeing things in threes. Threes are a very popular number when it comes to anatomy and physiology. And you can see that when I tell you about those little pockets, so you can see that it's not just directly on the white of the eye, it kind of cups in and comes underneath. And if you've ever had conjunctivitis, you don't want it. It's nasty. So I don't know whether you, but we had 3 little kids that, you know, in 3 years and 2 weeks. And if one started to get pink eye, everybody got eye drops, including mom and dad. Because it just spreads, it's crazy. And I mean, the difference with viral is kind of moist, but bacterial is that, you know, you wake up in the morning with the things stuck together. Very unpleasant. You have all sorts of debris on your eyelashes, and it's very painful. So this is a sty, is something with one of those glands. Again, that's something some people are prone to. I do not know how they treat it today. We used a topical agent called mercuric oxide. I do not know if it's still available today, but effectively it's one of those block glands. So here's the conjunctiva or conjunctiva, however you want to pronounce it. Transparent. Again, without going into the different bits, there's a little sac that I was trying to show you, and that's where contact lenses sit. Again, I've always been frightened about putting something in my eye, so I never even thought about getting contact lenses. And my sister, who had much worse vision than I do, or has, got contact lenses very early on when they were starting to be made, because she was more about her appearance. She's very concerned about that. I don't think she wears them now. I think she mostly just wears her glasses. So I'm like, I can't even look at somebody putting in contacts. You stick those things in your eye. Can't do it. You wear contacts? How do you do it? Oh, good. I can't look. You can't. You? Oh. You both look great with glasses. Very fashionable. Very fashionable. Studious, a nice look. If you're going out, different story entirely. So here's conjunctivitis and pink eye, contagious. From experience, the lacrimal apparatus, almost done with this little presentation. lacrimal gland, tears, all the stuff that's in it. But the best way is this. That's what I mean. It's being secreted here as we blink as frequently as we do. We lubricate and wash and cleanse, and at the same time, it's picked up here. But any of these openings, again, it's a two-way street. We have to look at when we review respiratory, we'll look at the nasal cavity. So they have little cul-de-sacs, those are into sinuses. We have the big opening, basically the eustachian tube or auditory tube. So that's middle ear infections. That's how they start and spread. It's very interesting. So basically, we'll leave it there, continuous with the lacrimal ducts. So all of those things can play us, and that's why we have eye symptoms and allergies too. We'll review this, and then you see the rest of them. Look at the eye muscles. They're good illustrations, better than eye draw. And then we're going to look at. I'll go over what's in these, and that really is the background for what we're going to be studying. This is a great illustration. So leave it there, and we'll see everybody in lab. All but one in an hour.